Hello, everyone. Today, Jahaira and I will be discussing Angelman syndrome in our first part one of our presentation. Here's today's agenda. It's highlighting what we'll be covering for this presentation. At its core, Angelman syndrome is a neurogenetic disorder, meaning it affects the nervous system and has a genetic cause. Specifically, it occurs when a person doesn't have a working copy of the protein called UBE3A, which should come from the mother's side. This missing protein leads to a range of challenges. People with Angelman syndrome often experience severe developmental delays. They have difficulty with movement and balance, and typically don't develop speech. They also face intellectual disabilities, may have seizures, and often struggle with sleep. Interestingly, this genetic quirk behind Angelman syndrome involves something called genetic imprinting. While we all have two copies, most genes, one from our mom and one from our dad, the UB3A gene is in our brain and only uses a copy from mom. In Angelman syndrome, this maternal copy is missing or not working. Now, you might hear an older term for this condition called happy puppet syndrome. This was originally used because frequently smiling and jerky movements often associated with these individuals. However, we've moved away from this term due to the fact that it's considered insensitive and doesn't capture the full complexity of this condition. It also fails to respect the dignity of those that have been affected. Today, we just simply call it Angelman syndrome after the doctor who first described it, named Harry Angelman.
Okay, so now we're going to talk about some key features and clinical symptoms. So, starting with clinical picture, this condition affects various aspects of the body, from facial characteristics to overall physical development. In the face, you might notice a smaller head size, a wider jaw, and often a flat back of the head. Many individuals have a distinctive smile, with their tongue protruding slightly. Their skin and hair are usually lighter than you'd expect based on family history. So now moving to the body, we frequently see spine curvature. As you can see on the pictures here on letter D, we have that spine curvature. Also decreased muscle tone, which can affect posture and movement. These individuals are typically shorter than average and may walk with a distinctive bent knee gait. Despite these physical challenges, one of the most striking features of Angelman syndrome is the remarkable happy disposition these individuals often display.
From early on, we see delays in reaching typical milestones. Parents might notice their child isn't crawling or babbling as expected around their first birthday. As they grow, movement becomes a challenge. You might observe trembling in their limbs, low muscle tone in the trunk, and an unsteady or wobbly walk. Neurologically, seizures are a big concern. About 80% of these individuals with AS experience them. They also tend to have overactive reflexes. Now, one of the most striking features is their behavior. Despite their challenges, these individuals often have remarkably happy demeanor. They laugh frequently, sometimes seemingly out of context. They might struggle with attention span, and often have trouble sleeping. Feeding can be tricky, especially early on, with difficulties in sucking, swallowing, and communication is another major hurdle. Most of these individuals with AS have little to no verbal speech. Interestingly, they often have unique sensory experiences. Many are very sensitive to heat, but less sensitive to pain. As far as a quickly detail, many have a fascinating attraction to water.
So now on to etiology. So AS is caused by the lack of functional UBE3A gene expression from the maternal allele. So normally we'd get one working copy from mom and another one from dad. But in our brain, something interesting happens. We only use mom's copy. This process is called genetic imprinting. So in AS, mom's copy of UBE3A isn't working properly. This can happen in a few ways. So about 70% of cases, there's a chunk of genetic material missing. We call this A deletion genotypes. The other 30% involve various other genetic hiccups, like mutations or other anomalies. So now you might wonder, what about dad's copy? Well, in our brain cells, dad's copy is naturally inactive. It's like having a spare tire that doesn't fit your car. It's there, but it doesn't help. Without a working UBE3A gene, the brain doesn't develop typically. This leads to developmental delays, epilepsy, and intellectual challenges, as we see in AS. Understanding these genetic underpinnings is crucial. It only helps us diagnose this condition, but also guides research into potential treatment future.
As far as the prevalence goes, Angelman syndrome impacts approximately 15,000 individuals globally, totaling around 500,000 people. In the US, it is estimated to occur 1 in every 12,000 to 20,000 live births, affecting individuals across all races and ethnicities, regardless of gender.
So now to clinical symptoms and impacted occupations. So first occupation being impacted, we'll start off with dressing. So a child with AS may struggle with dressing due to movement disorders, particularly somatodysprasia, which stems from hyperresponsiveness to tactile input and low proprioception. This affects their ability to engage in fine motor tasks like putting on a shirt or pants. So the second occupation impacted is sleep participation. So, a child with AS often experiences disrupted sleep patterns, such as insomnia and frequent night awakenings, due to excitability and hyperactivity. These disturbances impair the child's ability to not maintain a consistent bedtime routine and participate in restful sleep, which affects their daytime functioning and overall well being. The inability to achieve sufficient rest can lead to challenges with alertness, mood regulation, and engagement in daily activities. Now, the third occupation being impacted is feeding. So, a child with AS often will display hyperactivity characterized by excessive movement and difficulty remaining calm, which interferes with their ability to participate in seated mealtime routines. Additionally, ataxia and poor fine motor control make it challenging to grasp utensils, hindering self feeding and overall engagement in mealtime occupations. These difficulties extend to structured social activities, where hyperactivity and motor deficits affect participation in group settings, limiting opportunities to develop social skills and sustain attention during tasks. Now, lastly, the occupation being impacted is play. So, a child with AES faces challenges with play, particularly constructive play, due to developmental delays, including intellectual impairments, that limit their ability to plan and execute complex tasks. Hyperactivity, characterized by excessive movement, also plays a role, and difficulty staying calm further disrupts their ability to sustain attention during play activities. And sensory processing issues, such as somatodysprasia, caused by hyperresponsiveness to tactile input and low proprioception, also interferes with their motor coordination and ability to engage in structured play with peers.
Several anti-epileptic drugs, or AEDs, are commonly used, including clobazam, clonazepam, lamotrigine, levetiracetam, topiramate, etsokumimide, and valproate. While effective, these medications can lead to side effects such as irritability, impulsivity, and fatigue. For managing gastroesophageal reflux, or GERD, prokinetic medications may be prescribed, which can cause abdominal pain and dizziness. Additionally, low dose melatonin is often used as a supplement for insomnia, which potential side effects could include drowsiness and nausea.
So, now to the role of occupational therapy. So, therapy itself is usually aimed at reducing the signs and symptoms of the syndrome for the comfort and well being of the patient, but it does not address basic cause of the disease itself. So, OT interventions for AS will focus on improving functional independence, such as enhancing self care, daily living skills. So, for sensory regulation, we're working on managing sensory processing challenges. For motor control, just developing fine and gross motor skills for better coordination and social engagement to promote interaction and communication with peers, and with routines, trying to get a bedtime routine, toileting, and overall daily activities. OTs also perform assessments on individuals with AS to identify developmental delays, fine and gross motor, sensory processing, and self care challenges. These assessments guide personalized interventions that enhance functional independence and improve participation in daily activities. Because AS is multi-system disorder, patients with AS require multidisciplinary interventions throughout their lives. So they also have PT, applied behavior analysis, and a speech language pathologist. PT assists addressing motor challenges such as balance deficits, ataxia, and coordination. ABA assists addressing behavior challenges, communication deficits, and developing life skills. And SLP assists particularly in addressing communication and feeding difficulties. Vomino.
For the role of occupational therapy, the model of practice selected was a person and environmental occupation, which is a PEO. This was chosen for the child with AS due to its focus on the dynamic interaction between the child, the person, the surroundings, the environment, and the tasks they engage in, the occupation. This model allows for a holistic view of how the child's sensory, motor, and cognitive challenge impact the ability to perform meaningful activities. By examining how these modifications to the environment or task can enhance participation, the PEO model helps promote greater independence and engagement in daily occupations. For the frame of reference, the first frame of reference, we chose ASI, Airy Sensor Integration. It was selected because it can be used as a guiding frame of reference for a client with Angelman syndrome due to the sensory processing difficulties that are often observed with this population. These challenges can interfere with participation in daily activities such as play, self care, and social participation or interaction. ASI also is also designed to improve sensory integration, which is foundational for motor skill development and functional participation. Utilizing these evidence-based approach helps build adaptive responses to promote independence and engagement. For the second frame of reference, we chose biomechanical. This would address the core motor challenges in AS, which would target muscle strength, joint stability, movement patterns, and such. This can lead to an improved gait, better hand function, increased participation in daily activities. For instance, strengthening core muscles can help with sitting balance, while enhancing upper limb control may improve reading skills. For our third frame of reference, we chose occupational adaptation or OA. This approach is particularly relevant for children with AS because it emphasizes the individual's ability to adapt to their meaningful activities despite significant challenge. With this framework, we acknowledge that there are severe developmental delays and intellectual disabilities associated with AS, while still promoting or trying to promote autonomy and participation. For example, O8 might guide interventions to help a child with AS learn to use adaptive utensils for eating or develop alternative communication methods.
So now to prognosis. So patient prognosis, patients with AS usually require 24/7 supervision but can still maintain a good quality of life in semi-independent environments. Their quality of life may be reduced due to limited functional living skills, communication challenges, and high social needs, along with common health issues like epilepsy and gastrointestinal problems. Research shows that individuals with AS typically do not develop functional skills beyond the age of 3. Now, family and caregiver burden. Parents or caregivers of children with AS experience higher levels of stress in comparison with parents of typically developing children. Parents have reported that their child's AS has impact on many domains of their own life: emotional, need for constant vigilance, worry, anxiety, guilt, and depression. Their time, less time for other children, partner, or for work, or for social and leisure activities. Physical, reduced sleep, leading to fatigue and exhaustion. Back problems and injuries from aggressive behaviors. And finance, high health care costs coupled with less time to work.
In qualitative research, mothers of children with disabilities shared poignant insights into their experiences. One mother from Belgium remarked on her son's struggle with basic tasks. She stated that He struggles picking up things and moves them, such as picking up glass and putting it somewhere else a few meters away. This can illustrate the everyday challenges faced by families. Another mother from Chile emphasized the importance of communication, saying, if we could communicate better and understand each other, we could walk better throughout life. Otherwise, we'd just be dealing with the risk of making sure he doesn't fall. This can reflect the critical need for effective interaction to enhance mobility and safety. And lastly, a mother from the US expressed concern about her daughter's independence. She did note that she was hardly any independent. She has hardly any independence at all because of her inability to just go wherever she wants to go. Uh, these quotes exhibit a deep, profound impact of disability on both the individual and their families. It does, in essence, highlight the need for a very distinct supportive intervention.
So, our case study is Timmy is a 5-year-old boy who was diagnosed with AES at the age of 15 months. He currently lives with his parents, Sarah and John, and his older brother, Mike, who is 12 years old, in a 1 story home in Camarillo, California. The family is of Chinese descent and Christian and places a high value on togetherness, with Sundays often spent going to church together. Timmy is an active and cheerful boy who loves music and outdoor play but faces significant functional impairments. Timmy demonstrates the following strengths and preferences. He loves sensory play, watching videos on TV, and spending time with his brother. Timmy's speech is nonverbal and he communicates using gestures, facial expressions, and a few signs. He struggles with gross motor skills due to somatodyspraxia, leading to clumsiness, a wide base gait, and difficulty participating in physical activities like running and climbing. Sleep disturbances causes trouble falling asleep and frequent night awakenings, resulting in daytime fatigue that affects his mood and engagement. In social settings, Timmy has difficulty with turn taking and social cues, which impacts his ability to form friendships and participate in group play at preschool. He also needs assistance with dressing due to low proprioception, and he often struggles with sequencing tasks. Tim is currently receiving occupational therapy services at a pediatric outpatient clinic. His occupational therapy goals will focus on improving motor coordination, establishing a consistent sleep routine, and fostering social skills through structured play. Timmy's therapy program is closely coordinated with his family and preschool to ensure consistency and carryover of skills across the different settings.
Occupation number one would center on lower body dressing, which would be a vital component of ADLs. This task involves several key client factors. Cognitive challenges may arise, such as difficulty understanding the sequencing of the task, like which leg to put in first or how to pull the pants up. Additionally, fatigue from sleep disturbances can impact focus and performance during dressing. Proprioceptive functions play a significant role as well. Individuals may struggle to perceive the body's position in space, which would make it hard to orient and adjust pants accordingly. Muscle power is also another critical factor, as generalized muscle weakness is often seen in conditions like AS, and can hinder the ability to pull pants up or manage fasteners. With performance skill and patterns are essential for successful dressing. Many of these individuals face challenges in gripping the waistband or fabric, particularly if the fine motor control is impaired. Manipulating buttons and zippers can also be problematic due to the poor fine motor skills. Moving each pant leg can be difficult, especially with a wide base gait or ataxia, which are also common in AS. Finally, individuals may struggle with to calibrate the force needed when pulling up pants, leading to excessive or insufficient force. As far as occupation number two, it focuses on self feeding with a spoon. Essentially, which is an essential aspect of ADLs as well. This task would encompass several critical client factors. Individuals often face challenges with the mental function of sequencing complex movements, which would make it difficult to plan and execute steps involved in using a spoon. These would include scooping food and lifting it up to the mouth without spilling. Visual functions also play a significant role. Issues with visual motor integration, or VMI, can hinder the ability to coordinate hand movements with what they see. This would impact their effectiveness in guiding the spoon. The control of voluntary movement is another important factor we must consider, as the difficulties with eye hand coordination can complicate the feeding process. Additionally, impaired joint mobility or weakness in the arms, hands, or fingers can make grasping and controlling the spoon challenging. Performance skills and patterns further influence self feeding. Many of these individuals struggle to coordinate both hands effectively, such as using one hand to hold the bowl while the other scoops with the spoon. Lifting the spoon to the mouth without spilling is often a challenge due to poor motor coordination and control. Sequencing these steps, like scooping food, bringing it to the mouth and swallowing, and repeating, can be difficult to follow. Finally, individuals may have trouble adjusting their actions. By that, I mean doing things such as reorienting the spoon if it's in the wrong angle or shifting their position to prevent any spilling.
Thank you. Hope you enjoyed our presentation on AS.
These are our references. Thank you once again for listening to our presentation, and we hope you have a great day.